Good evening, everyone, and thank you for joining us as we discuss the current global crisis and the impact it has on South African communities. I am Stephanie Ramphel, Events Coordinator for SACAP, and I will be your host this evening. Just before we begin, there are a few house rules. We will be having a short Q&A session after the webinar, so please feel free to ask us any questions you may have at the Q&A box, which is located at the bottom of your screen. Kindly note that the session will be recorded and available on our social media channels. We are aware that there is high internet usage in the country, thus slowing down connection in some areas, and we ask for your patience. As is the case with many, we are also working from home, and we ask that you bear with us if you hear a microwave ping or a door slam or a truck passing in the background. To better help us understand how COVID-19 is affecting South African communities, we have Dr. Gordon Isaacs, who will be speaking about community mental health during a global pandemic, and Thelma Oppelt, who will tell us a bit more about where theory meets practice. Without any further ado, here is Dr. Gordon Isaacs.
Hi, everybody, and good evening to you. And thank you for joining SACAP's webinar on the global crisis and the pandemic on COVID-19. Before I start and talk to the context of community mental health, I would just like to say that our master's degree in community mental health promotion is underscored and underpinned, and I'm sure my colleague Thelma will agree with me, by a human rights and social justice approach, which is, I think, probably not negotiable, where we explore the intersectionalities within the context of mental health, the intersectionalities of systemic racism, gender violence, white privilege, the persons living with different abilities, ageism, vulnerable populations, and even singledom. So that underscores how our approach is value-based and also very, very community-orientated, as Thelma and I would say, nothing about us without us. But before I start, I think it's extremely important for me to unpack the meaning of the word crisis, because crisis in the context of mental health may be used very glibly. For example, I might have a crisis if I fail an exam, or I might have a crisis of divorce. But crisis usually represents a period that could be short or even extended of psychosocial and physical disequilibrium, in which, and I think importantly, these words are so important, a traumatic, dangerous, hazardous event or experience confronts a person or communities or society, or for that matter, globally. And this hazard or trauma may be unanticipated, that is sudden, it's a shock, there's a sense of feeling something that is acutely different, which you have no control over, and the anticipated or unanticipated crisis means that the danger or threat reduces the person's usual ways of coping with their defense structures, their usual and appropriate ways of coping that is familiar to them. And therefore, the crisis is usually the person's subjective response, the community's subjective response to the threat or the crisis, and not necessarily to the event itself. So one person may respond to corona with, let's say, untapped resilience, and another person may respond to corona, or a group or a community, with heightened anxiety, fear, terror, and threat. Now, a crisis can be seen to be literally an infringement on the homeostasis or balance that we previously experienced. And that homeostasis becomes what I call a crisis of adjustment. And the crisis of adjustment fundamentally means that if the crisis response is fundamentally dysfunctional, in other words, it becomes overloaded and we can't share what we feel, and we get a sense of overload in our heads, and the level of tension is insufficient to ward off anxiety, which is a definitive precursor to crisis, stress, and trauma, then the loss of state of being, the loss of control, the loss of self-esteem, and the object loss, the loss of work, the loss of a limb, the loss of a relationship become an imperative, and this always accompanies the crisis state. So if we look at the next slide, fundamentally we will see that when people experience a crisis, we can have a form of denial, we might have avoidance, we might retreat, and we can even protest. Stigma currently exists in the corona world. It's a different kind of stigma. It's a courtesy stigma by association. It feels as if people are observing others who wear masks, who don't wear masks. It feels like a leper-like syndrome. And in effect, a recent article has just been published which talks about the corona syndrome and its impact on mental health. Also, emotions may be denied, suppressed, and even over-controlled, and help-seeking behaviors thwarted. And in the corona context, help-seeking behaviors have been minimized due to lockdown. So, for example, going for ARV treatment, medication, sexual reproductive health, mother-to-child care, etc., have all been dislocated, and people are sitting with a certain amount of fear and anticipated fear, with what I would call a sense of an infodemic overload and an ambiguity of information, which leads to dissonant thinking, confusion, people defying authority, defying rules and laws, etc. And then also energy to compensate for these overloaded feelings may exist in erupting behaviors and feelings that are not necessarily familiar. And the erupting behaviors could be linked to what I call a coexisting feature of the pandemic. And that is not just the aging population, but the coexisting features of gender-based violence, substance abuse, poverty, and of course, hunger. So if we look at the targeting of simply people who have coexisting illnesses in terms of a medical model, we need to convert that into a biopsychosocial model where the inclusiveness of the psychosocial and cultural factors are engaged in understanding vulnerabilities which don't just necessarily locate themselves in the context of simply a targeted population. So hunger, nutrition, the loss of work, and the immense catastrophic interplay between those who are employed and not employed creates a mass amount of distress, as you can imagine, where millions of people whose identity in terms of either employment or unemployment have become fractured as a result of the violence. So we're sitting with a coexisting phenomenon of hunger, of violence, of gender-based violence, and also looking at vulnerable populations such as the queer community, the trans community, etc., who also have at their non-disposal access to mental health care facilities. And most importantly, crisis and trauma often resurrect unfinished business from the past. And what I mean by that is that transgenerational and intergenerational crises begin to emerge. For example, a person came to see me the other day about a crisis of around Corona. And as we engaged in the discussion, what emerged was previous traumas and crises around feeling dislocated and the sense of systemic disenfranchisement in the communities. And this became his primary concern as opposed to having to deal with Corona. So crises are incredibly important. And I ask students if they watch the news, particularly in courses that I teach on diversity and community mental health, social justice, advocacy and lobbying. And their response is, I don't really want to watch international news or the global responses. It's suicidal material. And what that tells me in terms of its metaphor is that people are experiencing vicarious trauma, compassion fatigue, burnout, and our mental health healthcare practitioners, as well as our frontline practitioners, are also at risk of developing the possibilities of burnout and compassion fatigue. Now, if we were to look at the next slide in terms of community mental health, it captures the realities of an emotional suffering of a community and reducing the suffering, and is mindful of values and traditions, and most importantly, culture, subculture, rituals, traditions of any community or collective community at a given point in time. And Professor Leslie Schwartz expands upon this in a very, I would say, interesting manner, where he talks about community mental health recognizes diversity and change, and that culture is fluid, and how people in an ever-changing and fluid and interconnected world would negotiate their lives and think and behave with respect to mental health and emotional health. And that the categories of the Western and non-Western discourses, he said, are our creation and neither reflect the diversity beliefs, often mutually contradictory, that people hold, nor the commonalities that exist across different groups of people. Now, the mental health structure in our country is at the moment, I believe, is absolutely suffering in terms of a fiscal and monetary bankruptcy. And despite a progressive mental health policy framework and strategic plan for South Africa, which affirms the belief that emotional growth and resilience, which is crucial for understanding mental health, and self-esteem and the identity of work are crucial to the nation, and that 16% of adults have a 12-month prevalence of mental health concerns, and 3/4 of persons who suffer and experience mental health distress and emotional health fractures do not receive mental health interventions. And if they do, some of the narratives that we hear are layered with metastasizing crises and unresolved trauma. And a significant proportion of our population also ingest some form of medication and or tincture to relieve their psychic pain. And to add to this discourse, some recent figures attest to the fact that the mental health care of our communities in terms of professional and paraprofessional persons is absolutely in terms of our population of 58 million people, excluding migrants and asylum seekers who may be documented, who may exist in the hundreds of thousands to the millions, is that we only have approximately 25,000 registered social workers, and that's a shortage of approximately 68,000. We have less than 1,000 psychiatrists, and 1/3 work in the public sector. The mental health care is often carried in primary care settings. For example, nurses and auxiliary nurses, and there are approximately 400,000 nurses for this population. And if we were to look at psychologists, the latest statistics suggest that there are approximately 13,000 psychologists. So you can see that our mental health services are underserved, they are undercapacitated, they are overloaded, and people who try to access these services often experience difficulties in terms of transport, in terms of distance, and in terms of stigma and attitudes that may prevail. Now, COVID-19 urgently needs a response to deal with mental illness, violence, gender-based violence, and particularly HIV and TB. It is reported that there is now an underserving of TB screening, an underserving of HIV screening, and we are concerned that through the lockdown, people who are on antiretrovirals, who may not have necessarily received antiretrovirals, may have non-compliance, develop a resistance to their ARVs, and then go into treatment failure. And we're also looking at the current and anticipated acute and delayed traumatic stress response. And I talk about delayed because people currently in this COVID may be coping. People may be coping at work, may be coping at home, but at a later stage, when they start to reassimilate their thinking and look backwards and see the losses and the adjustments they have to make, delayed trauma and traumatic responses may occur. And what I particularly am against is that the war imagery of the virus creates fear. The virus kills, it doesn't kill. The virus is an illness and people die from maybe a related coronavirus. They talk about the war, the command centers, the battlefields. And I think when we start militarizing an illness that is perhaps unseen, novel, it creates a metastasizing process and people become fearful on the one hand, and on the other hand, may even defy and protest, particularly if we have laws that regulate and legislate against privacy and our own sense of agency. Where if we are waging war on an unseen enemy, this feeds into fear and anxiety, which are hallmarks of both crisis and trauma. And mental illness and or emotional dysfunction are likely to increase because of the financial stress, the loss of work, anxiety, and self-isolation, and the realities of possible illness and death, and or suffering, and in particular, hunger, and the lack of proper nutrition surrounding us is ever present, and the fear of becoming in inverted commas, a victim or a survivor can cause sustained anxiety. And we know that anxiety has a neuronal pathway. It's a fight and flight response. We excrete adrenaline, noradrenaline, and cortisol, and our serotonin and dopamine levels drop. And this sustains anxiety and depression, which according to SADC, 1 in 4 persons already in South Africa speak to. and the unease often leading to domestic-based violence and gender-based violence, and certainly criminal activities. The last World Health Organization, their mental health survey of South Africa estimated that 30% of South Africans will suffer from a mental disorder over the course of their lifetime, and it is very likely that COVID-19 will increase these figures. And as I spoke about, crises are absolutely parallel to the concept of loss and the anticipation of hope and gain. And unless one can work with the loss, which includes grief and mourning and ritual grief and mourning, the anticipation of hope and gain doesn't seem to be in the grasp of persons. So if you remain attached to the lost object, in other words, grief, the loss of a job, the loss of a relationship, the loss of your home, the loss of work, the rise of homelessness, people who are placed into shelters with no sense of privacy, then we are looking at the elements of grief and mourning that are not necessarily appropriated correctly. Crisis resonates obviously with danger and trauma. And with only 5% of the treasury monies allocated to the health, that 5% goes to community-based mental health programs. And this places a dire economic strains on the country, and this will need to be a priority that will have to be re-examined. And I must also assure you that mental health is not separate from physical health, and the connection between the body, the mind, and the spirit and African cosmology has been compromised. And therefore, civil society, together with traditional leaders, must forge together and put in place mental health care mechanisms that are contextualized, that are current, and that involve community participation to deal not only with the devastating social impact of COVID-19, whether it be from economic fallout, cabin fever, and the lack of intimacy. And here I must quickly pause, because the lack of intimacy, for example, people who are single, people who are divorced, people who are separated from loved ones, people who need to be held, nourished, sexual intimacy, it can lead to further distress, and then imposed intimacy, where people are crowded into informal settlements, where the sense of privacy is unseen, and where intimacy becomes something that isn't nourishing, but becomes something that perhaps is extremely fearful. So overcrowding, deprivation, hunger, child and maternal care from the lockdowns, we need to initiate and sustain programs that can address the multiplicity of crises, the meta-crises, and trauma that coexist with features of gender-based violence, HIV, vulnerable populations, which include the homeless, migrant workers. It includes the asylum seekers. It includes people who are living with different abilities, women and children, and of course, teenage pregnancies, which is a huge concern. Stigma and misinformation curate further distress, and displaced communities, disenfranchised communities, and migrants, and informal dwellers, and those who are unemployed. Our schooling systems, which have been disrupted, are extremely vulnerable and cannot be excluded from interventions that will empathically embrace and hold the pain and incremental levels of stress, and often which are self-medicated with alcohol and other substances. Now, finally, and I'm sure Thelma will agree with me, that our SACAP's community-based participation action research is extremely important because students form relationships with leaders and gatekeepers, ambassadors, people and with the best evidence practice of needs analysis, community audits, the partnership between the mental health care practitioner and the community is equal. In other words, we look at power relationships, we look at the dismantling of patriarchy, we look at gender equity, we look at the feminist components that are so articulated by bell hooks, where we are gender sensitive and our language is appropriate. And our students, all our mental health care practitioners, traverse this landscape together so that power and academic prowess are actually diluted and the community leads. And I want to end off with the final slide. And the final slide is COVID-19 has indeed disrupted and burdened the mental health landscape, is in the traditional ways in which the technologies of capitalism, sexism, heterosexism, homo and transphobia, prejudice, human rights abuse, and structural racism generally operate. But what has remained thus far constant is the way the effects and affects of these technologies or messages or info overloads are compounded on those who disproportionately suffer at the hands of exploitative labor practices, unregulated unregulated informal economies, sexual and gender-based violence, and those who are living or impacted with HIV, TB, sexually transmitted infections, and the burden of care work, and certainly domestic responsibilities as well. Thank you, and I'd like to hand over to my colleague, Thelma.
Thank you so much, Gordon. So I would like us to maybe just for a moment conjure the image that comes with the word community. And even though you are perhaps so evolved that you don't no longer conjure that image of Black people in a rural township, maybe lining up for food parcels and that sort of thing, still the word community conjures images of a group living in a location that's not ideal. In some cases, it's a space that's not their choice. But it's this group of people sharing something, and it's that community that I just want to unpack a bit, and that sense of communion between people. So as we move into the definition of what is the theoretical underpinning of a lot of the work that's been done, we talk about community-based participatory action research, and at best, it's a mouthful. Even the acronym is a mouthful, as you may see there. But it's this approach that involves everyone. And as Gordon mentioned earlier, a lot of the work is underpinned by, you're not going to come to us and tell us about us because we are well acquainted with our circumstances. We are well acquainted with our inadequacies and with our shortcomings. And I think that's why when it came with this big bam, and you had to start looking at it from a historical perspective, and you're this beautiful rainbow nation, and as I would like to call it, stratified publics, right? We're not just one public. So you have this community that's made up of multiple layers, and we are embedded in our race, we are embedded in our gender, we know, like I said, shortfalls, we know our our level of poverty that extends beyond financial means. We know our cultural roots, though some of us may digress from it. We know there was a church, we know there was a mosque, we know there was this God that was forced down our throats, or we still worship and found our truth, right? But as the stratified public, like layers and layers of people, but within that person, there's multiple layers, and much like peeling an onion, each layer at a time, the role of the community-based researcher was to listen. And I think if we unpack a lot of what Gordon said, is no one is listening, right? Our government's not listening, our policymakers is not listening, our Minister of Health's not listening. Who's listening? So a community that's already lost everything, because face it, there's very little when you think of this community that I asked you to conjure an image of. They've got nothing, they're going nowhere, they may be riddled with gangsterism, violence, the works, you know. So what is it that this community could possibly offer you as a researcher? You as a savior, you as a community health worker wanting to swoop in and save everything. So yes, there's this global pandemic, but are we listening? So if we think back to this image of how COVID was pounced upon us, right? We had this military presence bombarding us with police style, apartheid style for some of our older people. And again, we were reminded of our race, our class, our shortcomings. We were reminded that actually my house didn't have this pantry. Actually, I didn't stock up. Actually, when the president announced lockdown, I didn't have a TV. So all those bad memories came back, right? But what the South Africans forgot, and I don't know, this is open to debate. The South Africans forgot it was a global crisis. And suddenly, our inequalities and our problems didn't matter to COVID-19. This virus was non-discriminated. So what was the problem then? And how were we faced with so many challenges and some of the trauma that Gordon's unpacked successfully? So the problem was we used to being policed. We used to being told what to do. We used to be told we don't have. We used to being told we must keep quiet. So a group living under those circumstances, we're going to meet it with resistance head on. And then already a failing mental health system was now pushing even more money towards health, but it was almost other health. And here were individuals who had battled with the mental health issues, because if you have a little bit of psychology, you know everything's about everything, right? And that means it's about the money, it's about the race, it's about the same old, same old. So why can COVID come into my mess and ask for more of this? So it was very challenging, but as the public was informed, I think the respect of sharing information, the respect of equipping the nation with information had this transitional process, and we went from this ugly, militant level 5 lockdown. Not only were the levels easing up, but if you look at it in pictures and you see the steps of how we progressed, right? So you start off with this rest, and why are you walking, and where are you going, what are you doing? And people very quickly adapted. Why? Because the information was shared honestly and openly. Yes, strategically, we don't take that away from the process, but the information was shared, and people started putting the cornerstones of escaping out of this nightmare that is their life, like education, like the health that was a lot of individuals through wealth, right? As much as Gordon says the physical health and mental health are separate, but a lot of people needed to be physically able to go to work or physically able to just go about their daily business. So people progressed from being so policed to wanting to live. And there was the sheer determination to comply, not because someone said so and not because laws were enforced, but because people can think for themselves. And this is what CBPAR is about, right? It's about, guess what? Yes, I know I'm poor. Yes, I know I'm going to die. yes, I know I don't have food in my cupboards, but if you spoke to me and I felt I had been given a hearing, I'll comply. And the nation transitioned during this time as there were WhatsApps and communication lines opened. People started trusting the process because they were affirmed. Even the outrageous ones who didn't accept the science of COVID, they started feeling empowered because guess what? Their emails, their hate mail was listened to. And that, though flawed, was the cornerstone of CBPAR, capacitizing a community. And what does that capacitation look like? It isn't giving you a job and a big purse full of money, but it's saying, I see you, I hear you, and I can't fix everything, but I'm going to try. And also saying that when I'm doing this, like when I'm sending children to school staggered, I have a plan. So as much as our policy environment is flawed, our government is corrupt, when the community participates fully, right? And what does that look like? We legitimize all processes within our democracy with the community buy-in. And this again is CBPAR. You can't swoop in and bring your crystal tower, custom-made change, custom-made plan, and dump it on a community. They'll just be, I see you. And they have had enough of that, okay? A community does not need to be reminded of the past. So what CBPAR does is places the person at the center of it. So you say, okay, all good and well, but what did an individual even have that's living in a township? And this is where the community assets have to be drawn out. And as Gordon has rightly said, the person to number of people in need of mental health interventions or plans or strategic actions are too few. We know that. Before we even had this mass mobilization for social workers or healthcare practitioners to be empowered, even before SACAP sends a fantastic cohort out into the world, the numbers still don't add up. So what we can do is create community-based participatory action researchers. Okay, how's that for a mouthful? And you say, okay, community-based means you're grounded in the needs, you understand the issues, the concerns, the strategies already in place, and you truly want to serve that community, okay? So where's the participation side of it? It's when you actively engage, what is it that this community really has in place already? And that is not a flippant exercise, because those healthcare workers that do not exist are going to be birthed out of those spaces. And again, I'm calling that community assets, right? You've got your civic associations, like those groups I spoke of earlier, seated in religion or traditions or clubs or even recreational groups. Your local job opportunities that are weird ones, not the government has created jobs, but the creche at the church where there's a ECD worker who maybe isn't accredited, but those are the local opportunities that present us with spaces within which to nurture, foster, and heal. So what does that healing look like? It's healing the system. And I think what's been unique with the COVID response is that it's been truly a South African response. We could not copy our friends in the West. And much of the critique of CBPAR work has been that it's been done in Latin America, and as much as we can draw on the examples and feed into what's existent in these spaces, we can't do something that isn't tailor-made for South Africa and truly copy it and force-fit us into that. No. So our COVID-19 response presents us not only with this beautiful opportunity to heal our land, pardon the buzzwords, but laying bare our inequalities, laying bare the cracks in our system and saying, okay, I'm going to heal this community one person at a time, because an individual is this building block within your bigger community, right? So it's individual assets like gifts of individuals, skills, education that's outside of our rigid frameworks of education, specific talents, networks, monetary resources, right? You don't have money, but you know someone who has money. How do you mobilize that and yield the whole system? So we do continue to look to policymakers. And this is the beautiful promise of CBPAR, right? Because now that you've listened and you've heard our story, so what? Okay, just another feel-good NGO moment, just another feel-good, ooh, we hear you, we understand how you are feeling. And this is in some ways been the research fatigue that communities have suffered. But the beautiful promise of CBPAR, and particularly the out-of-the-box kind of real action-taking steps, right, is grabbing your story, capturing it in a beautiful photograph. And that photograph isn't shelved somewhere in a community hall, but it's taken to those stakeholders. It's taken to those policymakers. And to me, that is the empowerment of the individual beyond what they believe they are capable of. So now you're saying, guess what, guy? Your picture that you took on that borrowed phone because you didn't have your own cell phone is now an A1 picture that's going to the local municipality to effect that change. And it sounds blue skies and it sounds like this big old dream, but it also involves. And please don't get me wrong, I'm completely against this whole thing of people must sort out their own problems. No, I do not believe in that. But I believe in finding the strength within an individual, taking that message to someone in power, be it policymaker, be it multiple stakeholders, and telling that person that their voice will be heard. And you are going to be that mouthpiece. You are going to be that speaker to make that message loud and clear. And to me, that would be the success of not only the South African tailor-made C19 response, but also underpinned by a beautiful theoretical framework that we can own. Because as researchers, sometimes you find that your theories are so prescriptive even, and it threatens South Africa and our freedoms in the same way a lot of the COVID trauma has threatened us, right? But if CBPAR comes and says, here's a theoretical toolkit that I present to you, I need your buy-in. It's for you, it's by you, it's about you. And person who brings it to you is also here to learn. I think we can really have an impact on the South African mental health landscape. So now, guys, my question is, what are you going to do? Okay? Because it's not up to the mental health care professionals council. It's not up to this big old boss somewhere in the cosmos, but it starts with you. And like I've said, those individual efforts can be pooled. And as we move towards multidisciplinarity, that one overworked psychiatrist is going to need you. That overworked social worker, that unpaid volunteer at the NGO needs you. So if you are willing, let's ask each and every one of us here to do about the South African mental health context. How am I going to make a difference? Thank you so much. Back to you, Stephanie.
Wow, I think it's safe to say that we've all really just taken in a wealth of information from both Thelma and Gordon regarding, community mental health, and then as well as the impact of COVID-19 on these South African communities and then our communities in itself. I'd just like to remind you all that you are welcome to pop any questions you may have in our Q&A box or our chat box. I think Gordon and Thelma are open to questions. We still have quite a bit of time, and we'll wait for your questions to come in. We have a question. Thelma, I think this would be best for you. Can you talk a bit about doing CBPAR? So what the module entails and how the module is done now during COVID-19.
Thanks so much for your question, Carl. And I don't know how everyone's COVID-19 research is going, but it's hard out there, okay, to not cut it short or not pull any wool over your eyes. It's the most difficult thing to do during COVID. But guess what? Our country has shifted. I don't know if you're familiar with Maslow's hierarchy of needs, but we've put Wi-Fi right there as a basic human need. We've all got devices. If you look at the cell phone penetration in Africa, even, not even only in South Africa, we've got towering giants around mobile data. We've got the most obscure places fully equipped with Wi-Fi. And that is what's making COVID-19 research possible, right? So yes, there are a lot of potential ethical pitfalls, but the research gets done. And if you look at some of the research that even fed into a lot of what the Minister Nkosazana Dlamini Zuma and Mkhize said, it came from research that had the CBPAR flavor, right? You had community telephonic surveys, you had WhatsApp messaging, you had emails, you had all of those platforms, and they were working. And if you just go now and you will see how many people are using free Wi-Fi, even the ones who don't have. And like I said, we're not looking at this I don't have needs-based perspective, but rather looking, where's the asset? Where's this community member with the cell phone who can tether the other one and do your interviews? Where's the one with the cell phone who can translate and interpret what is being asked? Where's the school with a functioning laptop where we can quickly do our online surveys? People have Facebook. People use WhatsApp. And I don't think we must discredit our communities to thrive in an industrial and fourth industrial, let me not use the hook, but definitely a technological age within which the CBPAR work can be done. And listening didn't require much. Listening just required your willingness to hear. So yeah, definitely you can go out there and you must legitimize the process a bit more with the POPI Act and all of that, but CBPAR can happen remotely. And you are welcome to send me some more specifics if Stephanie would allow, if anything else comes out, particularly how to get it done. Thank you.
Thank you, Thelma. Gordon, we have a question over here. It says, you speak of the country needing to relook at the gaps and the growing gaps of mental health service providers and increase support to those that need it to get it. What are things that we as individuals, organizations, etc., can do now to push the government to not just relook at what needs to be done, but to act upon it?
Am I unmuted?
Yes, you are. We can hear you.
Okay. What can we do within the context of how we can assist communities and others in terms of engaging in progressive mental health care activities is fundamentally to ask the question, how, first of all, do I feel about it? Do I have a safe space within which, in my head, that I feel that I can engage with a community in terms of reaching out on the one hand and tapping into resilience on the other hand, and also to, I would say, dare to take risks. The communities, in effect, despite the fact that they may have access to cell phones, etc., as well as to social media, are often tethered in. There's no sense of privacy. So what we can do is go into a community, speak to leaders, traditional healers, faith-based people, and try to understand how our skills, our humanity can really gel and synchronize with what a community might need. So, for example, if I were to go, if a community speaks to the fact that there's a dearth of, let's say, food, my recent contact with an NGO in a rural area looked at how communities gather together, and that there's a sense of community cohesiveness, and they would start gardening activities, greening the environment, and feel that that process empowers them, so that there isn't a sense of feeling that they are people receiving welfare, but at the same time creating opportunities for themselves and others. So it's collective sharing, it's collective messaging, it's collective networking. And I think that we mustn't fear to go into communities as if we are transgressing. What Thelma says is that we go in as mental health care practitioners, possibly at the invitation of communities, or if we are doing internships at particularly community-based organizations, and we surrender ourselves to the experience and the untapped resilience of the community or communities. And as Thelma says, it takes one person to create a pyramid of interventions. One person who might have leadership skills. So the mental health care practitioner can assist with that, can facilitate and collaborate, rather than saying, I'm coming into a community and I think we need to start a particular program. Because what happens with research is that communities are researched. They are target driven by donor funding. So you have to reach targets. So I'll need to see if I can dispense 500 condoms to 500 people. I've reached my target. It's donor driven. The community responds, but there's no feedback. So systemically, the community is seen as an object of research, as opposed to participating in knowledge. And the knowledge that the community gives to the mental health care worker is part of a learning process. And my definition, for example, of an intervention is not about knowing and not about being the expert, but is about finding out, so that we are not contaminated with theory, with principles or models only, but that we have a sense of feeling vulnerable ourselves and in touch with our own vulnerability, and therefore there's a sense of authenticity that comes across, and certainly, I believe, integrity. Then the community takes ownership of that process, and then the program or programs are sustained by the community, and the mental health care worker moves to the next space. So it's systemically ingrained, as opposed to top up, do some research, leave, and go to the next space. So community ownership is incredibly important. And that can, and the leader or leaders can exponentially endorse the ideas that the community mental health care worker may bring in. That includes volunteerism, networking, lobbying, and advocacy with the community in terms of protest. And the protest should reveal what the community needs. And if the protest can then inform policy directives, then you will find that policies and mental health policies are designed with the voices of the communities who are participating. So if I'm working in a community where there are people who are living with different abilities, let those people who have that particular subjective experience inform policies, so that the voicelessness of the community becomes heard. And by the voicelessness of the community being heard, the community, and I'm using it in a plural kind of way, actually feels understood. And I think that that's what Thelma is talking to be able to listen to beyond the message, beyond the narrative, and look at the subtexts and the rich tapestry of the oral history of that particular community that might have been buried and can resurface in the form of rituals, tradition, song, dance, photography, and of course, spirituality. And we can't underestimate the sense of spirituality within our communities, the sense of hope, the sense of traumatic growth, which can occur as a result of communities that might be disenfranchised, or communities that even are not disenfranchised, who also experience trauma and or crises that they feel might be irreconcilable. So I think that how we can help is to first of all look at what we want to do. Are we going into rescue, which I don't think is a good idea, or are we going in as a vulnerable person with some kind of knowledge, and that we can then source from the community, as I've said before, an individual, a leader, a faith-based leader, as Thelma spoke about, creches, mothers. For example, one of the community-based programs that I'm working with is the mothers. It's called Mothers for the Future. And this is how female sex workers who are mothers are actually coalescing and organizing creches, daycare centers for the children of female sex workers who might be left behind, and how this program has originated from the needs of mothers who themselves have collectively come and said, what can we do for our children? So we need to also look at how legislation indirectly can negatively or positively impact on vulnerable populations. And that in and of itself needs to be addressed. Hope that answers.
Thank you so much, Gordon. That was a very, very robust answer, and I think we've all taken quite a bit from that. I'd just like to let you know that if anybody would like to know more about the CBPAR, please feel free to let us know in the chat box. Pop us your email address via the Q&A if you'd like it to be private, and we will definitely get back to you with more information on that. We'd like to thank you all so much for joining us this evening. Once again, a huge thank you to Gordon and Thelma for the amount of information you've shared with us this evening. If you'd like to attend any of our virtual open days or online open days and find out more about our courses, please do visit our website. Follow us on social media. You can also keep an eye on our YouTube channel for the recording of this webinar. Thank you once again, and have a lovely evening further.
Thank you.